Welcome to our next generation NCLEX-RN review session, where we'll dive into an unfolding pediatric case study. I'm your lecturer, here to guide you through critical thinking and clinical decision making. Get ready to engage, analyze, and apply your knowledge to ensure safe, effective patient care. Let's get started with the first item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
We have a bow tie. So let's scan through the scenario here. It says a 9-year-old Hispanic male presents to the emergency department after sustaining electrical burns from a damaged battery charger, 120 volts alternating current. While playing in the garage, he grasped exposed wires, receiving an electric shock that caused burns to his right thumb, an index finger, left palm, and right chest. He fell backward, briefly lost bladder control, but sustained no additional trauma. His mother, who witnessed the incident, reports no loss of consciousness, seizures, or bleeding. The patient is triaged immediately due to the electrical injury and risk for complications. We have the following information in this patient's medical history: has mild asthma managed with albuterol inhaler as needed, no known allergies, up to date for the immunizations, uses albuterol inhaler as needed, and lives with parents, no tobacco exposure, and the family history, it says no cardiac or neurological disorders. We also have information about the emergency department assessment findings for this patient. Generally, patient is alert, oriented, in mild distress due to pain, temperature of 99.1 degrees Fahrenheit, pulse of 110 beats per minute, respiratory rate of 26 cycles per minute, blood pressure 130/56, weight is 33 kilograms, oxygen saturation of 97% of room air, pupils are equal, round, reactive to light, tympanic membranes are intact, oral mucosa moist. For the neck area, it's supple, no lymphadenopathy, and lungs are clear. 1.5 centimeter brown lesion with erythematous borders on the right chest at the fourth intercostal space. For cardiovascular assessment, it's irregular rhythm. For the heart, no murmurs or gallops, normal pulses, no edema. Abdomen is soft, non-tender, normal bowel sounds. Now for the integumentary system, it said burns in the right thumb, measuring 1 square centimeter. For the right index finger, there's 1 square centimeter. In the left palm area, there's 4 square centimeter, and right chest 1.5 square centimeter, totaling 7.5 square centimeter, with the total body surface area of 0.075%. And neurologic wise, it's intact, no focal deficits. Moving on, we have lab results here. For sodium, it said 139, potassium 3.7, chloride 102, BUN 14, creatinine 0.5, glucose 108, calcium 9.2, troponin I less than 0.04, CPK 125, CKMB 1.4, white blood cell count 10.2, a hemoglobin of 13, and platelets of 270. All right, moving on to our diagnostic results. ECG showed sinus rhythm with occasional premature atrial contractions, or PACs, possible left ventricular hypertrophy. Echocardiogram has been ordered pending results to assess for structural abnormalities. We also have the medical provider orders listed. With cardiac monitoring, there's an order for continuous telemetry and neurovascular checks every 2 hours for bilateral upper extremities, and extremity elevation to affected extremities continuously. We have orders for consultations for surgery, indicated for burn management, and cardiology for the arrhythmia evaluation, and serial ECGs every 4 hours for 24 hours. And we have a list of medication orders, including D5 half normal saline at 100% maintenance. That's about 55 mL per hour. Acetaminophen 15 milligrams per kilo, orally as needed. And morphine, we have 0.1 milligrams per kilo IV for breakthrough pain. And apply silver sulfadiazine 1% cream in a 1 to 2 millimeter layer to all burns once daily, with dressing changes. Clindamycin 10 milligrams per kilo IV every 8 hours to start immediately. Apply bacitracin ointment 500 units per gram in a thin layer to the chest burn once daily, and administer 20 mL per kilo normal saline IV bolus over 30 minutes. Now, moving into the nurse's progress notes, these are the documentation. At around 10 a.m., it said, patient arrived in the emergency department alert-oriented ×3, reporting pain at burn sites, 6 out of 10 on pediatric pain scale. Vital signs: temperature 99.1 degrees Fahrenheit, pulse of 110, respirations 26, blood pressure 130/56, oxygen saturation of 97%, irregular heart rhythm noted on auscultation, IV access established in left forearm, D5 half normal saline infusing at 55 mL per hour, 12 lead ECG completed showing PACs, silver sulfadiazine applied to burns, extremities elevated, neurovascular checks intact, awaiting surgery and cardiology consults. At 12 p.m., patient reports reduced pain, 3 out of 10 after a dose of acetaminophen, pulse 108 beats per minute, rhythm irregular, neurovascular checks remain intact, cardiology recommends serial ECGs and echocardiogram, surgery advises continued wound care and monitoring for compartment syndrome, patient's mother educated on care plan. So your task here is to fill in the diagram by choosing from the options provided to identify the potential complication the patient may experience, 2 nursing actions, and 2 parameters to monitor. So we got the following options for the potential complication, naming renal failure, compartment syndrome, cardiac arrhythmia, wound infection, and rhabdomyolysis. For the nursing actions are the following: initiate continuous cardiac monitoring, administer oxygen at 2 liters per minute nasal cannula, apply sulfadiazine to burns, administer acetaminophen 15 milligrams per kilo PO as needed, start IV D5 half NS at 55 mL per hour, notify cardiology for urgent consultation. And for the parameters to monitor, we have the following options: temperature every 4 hours, cardiac rhythm on telemetry, oxygen saturation, pain level using a pediatric pain scale, wound appearance for erythema and drainage, lastly, urine output hourly. So this time you can pause this video so you can probably rewind and rescan the different medical information here before you decide into choosing the different options. So I hope that you did that already. Now let's get into how to approach this question. So I want you to pinpoint the most urgent and life-threatening complication in this case scenario from, of course, we're talking about the complication from the patient's electrical injury. And so to answer this item correctly, I want you to apply the NCSBN clinical judgment measurement model for you to prioritize the cues and also to choose those interventions that prevent any progression of this problem. So, for the potential complication, the correct answer here is cardiac arrhythmia. So, we already noted in the case that the patient is having irregular heart rhythm and the ECG is showing premature atrial contractions, which indicate a risk of worsening arrhythmias due to myocardial irritation from the electrical injury. And so here, arrhythmias are a priority because they can progress to life-threatening conditions like ventricular tachycardia or fibrillation. And this makes cardiac arrhythmia the most immediate concern compared to the other complication. For the incorrect options, such as the compartment syndrome, we know that the patient has burns in different areas of the body, but at this point, there are no other signs of edema, severe pain, or neurovascular deficits, which are necessary for compartment syndrome. And so without these cues, compartment syndrome is not an immediate risk. And the arrhythmia, supported by the cardiac findings, is of a higher priority. Now, the other options, such as wound infection, well, at this time, the burns show erythematous borders, but no fever. There's no drainage at the admission, during the admission time, I should say, and it indicates no active infection this time. And we know that infection is a potential future risk, not an immediate threat. Now, arrhythmia is more urgent due to its potential for rapid deterioration. That's why we are selecting that. What about the rhabdomyolysis? Now, take a look into the CPK, or you can review into the lab value. It's 125 units per liter, and the creatinine of 0.5 milligrams per deciliter. These levels show no evidence of significant muscle damage. And remember that rhabdomyolysis is not supported by the current lab data, making it less urgent this time. Now, what else? We have renal failure in the top list. Now, I want you to go back into the lab value. The BUN is 14 milligrams per deciliter in this patient. Creatinine level is 0.5 milligrams per deciliter. Those two indicate intact renal function and no signs of renal impairment. And the renal failure is not a current risk at this point, especially without rhabdomyolysis. Now, again, arrhythmia is the more immediate complication based on the clinical cues. Now, let's move on into the left boxes here, talking about the nursing actions. So I hope that you have already selected those two correct nursing actions. And one of those interventions is the initiate continuous cardiac monitoring. This is very critical in order for us to detect real-time changes in the patient's irregular rhythm and the PACs, which could worsen after an electrical injury. And this nursing action directly addresses the risk, or it addresses the risk of arrhythmia progression, also aligning with the provider's order for ongoing surveillance. And so that's why we are selecting this one. Now, the other nursing action should be to notify cardiology for urgent consultation. So the patient's PACs and irregular rhythm require specialist evaluation to manage potential arrhythmia progression. And notifying cardiology will ensure timely expert intervention as ordered by the ED, physician. And so this action will support effective arrhythmia management. Now, let's talk about the other incorrect options here, which includes the administer oxygen at 2 liters per minute nasal cannula. Now, going back into the patient's vital signs, the saturation is 97% on room air. No indication of hypoxia. So oxygen administration is not needed for arrhythmia management. There's no indication that there's hypoxemia. There's no respiratory distress. So we're not going to pick that one. And this alone does not address the cardiac complication. Now, the other incorrect option is apply silver sulfadiazine to burns. Why is this incorrect? We know that this is used to address burns to prevent infection, but this is not going to be helpful in managing arrhythmias. Remember that our central problem is cardiac arrhythmia. Now, this action, again, is irrelevant to addressing the irregular heart rhythm. Now, the other incorrect option is administer acetaminophen 15 milligrams per kilo as PO as needed. This is intended to relieve pain, but it does not treat or prevent arrhythmias. We know that pain management is important, but again, this is unrelated to the cardiac complication, and this does not address the priority of arrhythmia. We also have start IV D5 half normal saline at 55 ml an hour, which is intended to maintain hydration with normal electrolytes, but there's no dehydration noted in our patient. But again, this will not directly manage the arrhythmias, and that's why we are not selecting this one. This is a form of a supportive care, but it's not going to target the cardiac complication. Now, let's move forward into the 2 boxes for the parameters to monitor. The first of the 2 interventions, it's not ranked into the priority, but randomly selecting here, we have cardiac rhythm on telemetry. This is going to help us track those changes in the PACs, and this will help detect worsening of arrhythmias real time. And also, it will directly evaluate the effectiveness of our interventions for the cardiac complication. Also, it is aligned with the need for continuous monitoring. Now, the other intervention, or parameter, I should say, is the oxygen saturation via pulse oximetry. This will help ensure adequate systemic perfusion, as we know that arrhythmias could reduce the cardiac output. It can cause hypoxia. Though oxygen saturation currently is 97%, but monitoring is very critical to assess the impact of arrhythmia into the oxygenation. And so this will also complement the rhythm monitoring for comprehensive care. Now we have pain level using a pediatric pain scale as one of the incorrect option. We know that the patient has a pain level of 6 out of 10, but this is not a direct indicator of arrhythmia status. And though we have to monitor the pain level, but this is more leaning towards patient comfort. It does not help evaluate the cardiac rhythm, or it does not help evaluate arrhythmia management. So again, this is unrelated to the cardiac complication, even though this is a good intervention, but not targeting into what we want for cardiac arrhythmia. Another incorrect option is wound appearance for erythema and drainage. This is an intervention that will help detect infection, but not for arrhythmia progression. And the burns condition is unrelated to the cardiac status, so we are eliminating this one because it does not assess the effectiveness of arrhythmia interventions. We also have urine output hourly. So go back into the lab values. There's normal renal labs such as the BUN, creatinine, showing no signs of rhabdomyolysis or renal issues. So making this urine output monitoring irrelevant for the arrhythmia issue. And again, not a priority for the cardiac complication. And we also have temperature every 4 hours. This is going back into the patient's vital signs. He had a value of 99.1 degrees Fahrenheit, something that we need to keep an eye out during the admission. And there's no presence of fever right now at this point. That's the word right there. And so this is not going to really address the, this is not a monitoring tool for us to detect cardiac arrhythmia. All right, so unrelated to the cardiac rhythm management. I hope that you were able to catch into the different actions here and also the parameters to monitor and the real issue that you need to address. Let's move on into our next test type. We have a hotspot highlight test item. And let's get to in the scenario. We have an update. It says the nurse is reviewing the healthcare provider's orders for the 9-year-old patient in the ED following an electrical injury. Based on the current clinical presentation, highlight the orders that are contraindicated or inappropriate for this patient's treatment. So let's scan the medical provider orders. There's an order for continuous telemetry, neurovascular checks every 2 hours for bilateral upper extremities, extremity elevation, elevate affected extremities continuously, consultation for surgery and cardiology. We have diagnostic follow-up, serial ECGs every 4 hours for 24 hours, and medications, D5 half normal saline at 100% maintenance, 55 mL per hour, acetaminophen 15 milligrams per kilo every 4 hours, orally as needed for pain and fever, morphine 0.1 milligram per kilo IV every 4 hours for breakthrough pain, apply silver sulfadiazine 1% cream in a 1 to 2 millimeter layer to all burns once daily with dressing changes, clindamycin 10 milligram per kilo IV every 8 hours to start immediately. Apply bacitracin ointment 500 units per gram in a thin layer to the chest burn once daily. Administer lidocaine 1 milligram per kilo IV bolus now, and administer 20 mL per kilo normal saline IV bolus over 30 minutes. Now, how are you going to approach this test item? Well, remember that with the next generation NCLEX-RN item, it's going to test your clinical judgment in identifying inappropriate healthcare provider orders, which is a key for patient safety. Also, a key in determining those inappropriate and contraindicated orders. Now, I also want you to recognize and analyze the cues. That's your layer 1 and 2 in the NCSBN clinical judgment measurement model. So I want you to scan the scenario for the critical cues. We have the irregular rhythm, the PACs, the normal troponin CPK, stable vital signs, blood pressure 130 over 56, small burns, there's no infection signs. And if you want to rewind to review the vital signs, you're going to see there that the temperature is 99.1 degrees Fahrenheit. There's also white blood cell count and other renal lab values. So I want you to analyze those cues to identify the treatment needs, such as arrhythmia monitoring, burn care, maintenance fluids, and no need for immediate antibiotics or antiarrhythmics or possibly fluid boluses. So I want you to go through each of those. Now, next is to prioritize the hypothesis. This is layer 3. So you have to compare each order to the patient's condition. Now, those appropriate orders should align with the electric injury care, and those inappropriate orders are premature, those are contraindicated or considered risky. And lastly, I want you to generate those solutions. This is also to take action. That's your layers 4 and 5. And here, it's time for you to identify the orders that could harm the patient, And I want you to highlight only the incorrect orders to correct the plan. And lastly, you have to evaluate the outcomes by highlighting the incorrect orders, which will prevent harm, and also identify those appropriate orders, which are going to support patient care, also improving patient outcomes. So let's get into the answers for this test item. So what is the first order that you should highlight here? In no particular order. One of those orders that you should highlight is the clindamycin 10 milligrams per kilo IV every 8 hours to start immediately. Why are you going to question this? And why there's a need for you to clarify this order? Now, the rationale is that when the child was admitted, there were no signs of infection. The temperature was 99.1 degrees Fahrenheit. The white blood cell count was normal at 10.2, and the burns appeared red but showed no pus or drainage. And this time, if you give the antibiotics at this stage, it could cause unnecessary side effects and could contribute to antibiotic resistance. Now, if you're probably thinking about empiric IV antibiotics, this is not a common practice at ED admission in this kind of scenario due to the absence of infection signs. Well, the empiric antibiotic therapy will become appropriate only when the infection cues emerge. Maybe there's going to be increased drainage, there's going to be presence of pus. Now, why is this inappropriate? It's because when you start the antibiotics too early without clear evidence of infection, it's not justified. So for you to prevent or to promote safety in this client, you have to monitor the child and reassess the wound condition for any infection signs. Now, what is your responsibility here in this case, since this is an inaccurate or inappropriate order? So here's the steps that you should be doing. You're going to withhold the medication, so you don't start the clindamycin, noting that there's no fever, the white blood cell count is normal, there's no drainage, which means there's no infection to treat. So around this time, what you need to do is notify and call the emergency department physician. You're going to tell him, I'm concerned about starting clindamycin now since there's no fever or drainage. Can we hold it and monitor for infection? So that's going to be your verbiage. Now, if the physician insists in having you administer the medication, then your next step would be to contact the charge nurse, citing the risks of resistance and the side effects of administering this medication. Next is to document this in the medical record, the steps you took to clarify the order, and then you go ahead and monitor for signs of infection. Well, that would be good if the healthcare provider will change that order in order for you to just watch the infection signs first, and then probably that standing order will be kept in the healthcare provider order queues. But around this time, there's no valid explanation why we should administer this drug. Now, the next medication that you should question or need clarification is to administer the lidocaine 1 milligram per kilo IV bolus. Now, we know that the ECG shows premature atrial contractions or PACs, but when you look into the troponin and the CKMB, those are normal, and these lab values confirm there's no heart damage. And remember that in children, especially after electrical injuries, the PACs are usually harmless and often go away on their own without medication. And I want you to remember that lidocaine is meant for serious ventricular arrhythmias, not for mild atrial ones like the PACs. And so if you're going to use this medication in this scenario, it could lead to side effects such as slow heart rate and possibly seizures. And again, lidocaine is not intended for PACs. It could do more harm than good for this patient. So what would be your next step here? You're going to withhold the medication and also contact the physician to report that the PACs are stable and cardiac enzymes are normal. Probably recommend canceling the lidocaine order and continuing cardiac monitoring per cardiology guidance. And if the provider still requests lidocaine to be administered now, remember that the order is bolus now, then it's time for you to involve the charge nurse and explain the risks of adverse effects such as bradycardia or seizures in the pediatric patient. Next is to document. Note what you have done in order to clarify this order that you withheld the medication due to stable PACs, and hopefully the physician has canceled the order and making sure that you are continuing the telemetry monitoring for this patient. Now, what else do we need to highlight here as something that we need to, so we have the next order: administer 20 mLs per kilo normal saline IV bolus over 30 minutes. That's also inappropriate. Take a look into the patient's vital signs again. The blood pressure is within normal range. Heart rate is about 110. The creatinine level is also in the normal range. They are stable. Patient is well hydrated. There's no signs of fluid loss. And if you're going to administer the fluid bolus in the situation, this could cause fluid overload, which is very risky in children with burns due to the chance of worsening the swelling. And of course, the patient doesn't need rapid fluid replacement in this case. So what we are going to do here instead is to maintain the other IV fluid maintenance fluids, which is a safer choice for a stable pediatric burn patient. So you're going to withhold the bolus order for this IV fluid and notify the ED healthcare provider to report the child's vital signs and laboratory results. And you can recommend continuing maintenance IV fluids at 55 mL per hour instead of giving the bolus. Again, you're going to need to escalate this. If the physician continues to request the bolus, you have to involve the charge nurse and explain the potential risks, including pulmonary edema and worsening tissue edema from over fluid resuscitation. And don't forget to document of what you have done regarding this order. Now, the other order that you needs to be clarified is apply bacitracin ointment 500 units per gram in a thin layer to the chest burn once daily. And why is this highlighted? Now, the reason for that is bacitracin is not appropriate for the chest burn near the fourth intercostal space because it only targets some gram-positive bacteria and it does not protect against common burn infections like Pseudomonas. It's thick, its greasy texture can also trap the moisture, which will increase the risk of skin breakdown or what we call as maceration in this sensitive area. So in contrast, the sulfur sulfadiazine is the preferred antibiotic treatment because it covers a wider range of bacteria. It will also penetrate tissue more effectively and it's less likely to cause skin damage. And so this makes it a safer and more effective option for treating electrical burns in this higher risk areas like the chest. Now, if the medical provider is going to insist that you're going to administer this medication, again, you're going to have to escalate this and involve the charge nurse. So around this time, withhold administering this medication, notify the medical provider, escalate, document in the medical record of the actions that you have taken, and monitor the burning areas, especially the chest burn, for any signs of infection, any drainage or maceration, and confirm that sulfur sulfadiazine is enough to prevent early infection and it's supposed to support proper healing. Now, let's move into the incorrect phrases and orders. So One of those is the D5 half NS at 100% maintenance, 55 mLs per hour. Why is this incorrect in this scenario? Well, it's because it can support adequate hydration for this 33 kilogram child, and there's no signs of dehydration or overload. And so this IV fluid rate aligns with the standard pediatric fluid maintenance guidelines. Another incorrect item here, or incorrect order, is continuous cardiac monitoring or telemetry, because we definitely need to monitor the patient's PACs to detect any potential worsening of arrhythmias early. Another is the pain management, giving acetaminophen 15 milligrams per kilo every 4 hours orally as needed for pain and fever, and morphine 0.1 milligram per kilo IV every 4 hours for breakthrough pain. So these two medications for pain control are within the appropriate weight-based dosages to effectively treat burn pain. Now we have the apply silver sulfadiazine 1% cream in a 1 to 2 millimeter layer to all burns once daily with dressing changes. This is also an incorrect order. This is an incorrect option for you to highlight, I should say, because this is part of the standard burn care to prevent infection and promote wound healing. And the order to do every 2 hours of neurovascular checks for bilateral upper extremities is also critical for early detection of compartment syndrome, especially in burn injuries to the upper extremities. And the order to elevate affected extremities continuously will also prevent and also to control edema in burn affected limbs with minimal risk. And the order for the consultations for surgery and cardiology, these are also critical in making sure that the patient will receive multidisciplinary care promptly. And of course, this will address wound depth and healing, and the cardiology will address the arrhythmias. And we have the serial ECGs every 4 hours for 24 hours is also an order that's not supposed to be highlighted here, because this is going to be required to monitor cardiac rhythm trends in a patient with known premature atrial contractions to promptly detect any progression or worsening of the arrhythmias. Let's move on into our next test item, which is a matrix multiple choice.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
And let's go into the scenario. Looks like it's updated. It says nurse's progress notes day 1. And pay attention to the time here. 7 p.m. It says, transferred from emergency department at 5:30 p.m. Alert-oriented pain 2 out of 10 after acetaminophen 15 milligrams per kilo PO at 4:30 p.m. Chest burn 1.5 square centimeter in the fourth intercostal space shows increased erythema, minimal drainage. IV D5 half normal saline at 55 mL per hour continues. Neurovascular checks intact. Extremities elevated. Telemetry shows PACs unchanged. Plan to continue wound care telemetry, monitor infection, and arrhythmia. Now pay attention to the vital signs here at 7 p.m. Temperature is 100.4 degrees Fahrenheit. Pulse rate of 108 beats per minute. Respirations of 24 cycles per minute. Blood pressure of 128/54. Saturation of 98% on room air. 15 minutes later, the temperature is 100.3 degrees Fahrenheit. Pulse is 106 beats per minute. Respirations of 24 cycles per minute. Blood pressure 126/52, and saturation remains the same. Now, for each intervention, determine whether it is appropriate or inappropriate for managing the suspected infection at this stage. So, for you to answer this question, I want you to approach this question by first evaluating each intervention based on the patient's new elevation of the temperature and the erythema in the wound. And so you have to determine which interventions can effectively address a suspected infection. Next, you have to read thoroughly each intervention and decide whether it's appropriate or inappropriate due to a lack of necessity or if it can cause harm to the patient. Now, let's get into the first intervention here. It says, obtain a wound culture from the chest burn before initiating antibiotics. What do you think is the answer here? The answer here is appropriate. So when you're using the clinical judgment model, the nurse should recognize the cues, specifically the new elevation of the temperature and also increasing redness around the burn. That points to a possible wound infection. So before you jump to the treatment, you as a nurse should analyze those cues and make sure that you consider the best way to confirm the cause. So when you are going to obtain a wound culture first, this will help identify the specific pathogen involved, and this will also support the hypothesis that the wound is infected and that targeted treatment is needed. And by collecting the culture before starting the antibiotics, we are avoiding compromise of the test result. And the solution here is to collect the culture, and the action is to follow through promptly. That's why this decision is appropriate. It aligns with the evidence-based infection control and also guides accurate therapy. Now, moving into the next intervention, it says initiate clindamycin 10 milligrams per kilo IV every 8 hours as prescribed after obtaining culture. The answer here is appropriate. And so I want you to really decipher the change here in the clindamycin order compared to the original order. Remember that the physician stated that it should be administered immediately. But here, the intervention specifically mentions that the clindamycin is going to be administered every 8 hours as prescribed after obtaining the culture. So the nurse must carry out the prescription for the clindamycin, and this recognizes that early antibiotic therapy can help prevent progression to a more serious infection. So around this time, there's already signs of infection. There's fever, there is increased erythema, right? And these all support the manifestations of infection here. They could be spreading, and the child is at risk this time. And the nurse should analyze the situation and understand that clindamycin is a strong choice for soft tissue infections and may also cover MRSA. So the nurse here will use the hypothesis that a prompt response will help limit the spread of infection in the patient. And take note that administering this antibiotic after the culture has been done is the best solution, and taking this action is appropriate clearly for managing this patient with a suspected infection. Now let's move on into our next intervention. It says increase IV fluid rate to 150% maintenance, which equates to 82.5 mLs per hour. What do you think about this one? This is inappropriate because the vital signs and perfusion are stable. There are no signs of dehydration, no signs of hypotension or shock. So for the CJMM, or the clinical judgment measurement model, this begins with recognizing the stable cues like normal blood pressure and normal urine output. And when you're analyzing these cues, it's going to tell you that the fluid resuscitation is not necessary at this stage. Okay, so the hypothesis that fluid bolus is needed does not really hold up, and increasing the IV fluid rate is unnecessary. This could cause harm, and the better solution is to maintain the current fluid order. So escalating the fluids to 150% is inappropriate, and it doesn't match to the patient's clinical need. Now let's move on to our next order or intervention. It says monitor temperature and wound appearance every 4 hours. This is appropriate because with a suspected infection, it's critical for us to monitor the changes in both the vital signs and the wound itself. And recognizing that the fever has started and redness is spreading can help the nurse understand that things could evolve quickly. And by analyzing this trend, the nurse can prioritize the need for close monitoring to catch early signs of worsening infection. Moving on to the next intervention, it says apply mupirocin ointment to the chest burn. This is inappropriate because burn wounds typically require broad spectrum antibiotic coverage, and recognizing the nature of the wound and the signs of infection, the nurse should question whether mupirocin is effective in this context. Now, analyzing this cue, the nurse recalls that mupirocin works mainly against certain gram-positive bacteria, and this is more suitable for minor skin infections, but not for burns. And we already have an existing order for the silver sulfadiazine, which is more appropriate for burn coverage. And so using the mupirocin could lead to inadequate treatment. So we're not going to administer or carry out this action. Now, what about administer acetaminophen 15 milligrams per kilo PO for fever? This is appropriate because, of course, the fever can make the child uncomfortable even at low-grade levels. And this is recognizing the cue of elevated temperature and the mild distress. And so here, the nurse evaluates the benefits of giving the acetaminophen. Now, the analysis shows that lowering the fever may improve comfort and reduce metabolic stress. And since this is a standing, there's a standing PRN order, the nurse can act promptly, and the solution is straightforward. Give the appropriate dose. So this is a safe, supportive, and appropriate intervention. Let's move on into our next intervention. It says obtain an order for a complete blood count CBC immediately. What do you think about this? Well, unfortunately, this is inappropriate even though there's a mild fever. The child recently had a complete blood count during admission and it showed normal values, white blood cell count of 10.2, right? And so at this point, the nurse recognizes that the current information does not point to a new or worsening systemic infection requiring immediate lab work. And analyzing the clinical picture here shows that repeating the complete blood count at this time likely won't change management. So the better solution is to monitor the patient's progress and reassess later if the symptoms worsen. So jumping to another CBC now would just be considered inappropriate and possibly unnecessary. Let's move forward to our next test item. We have a trend test item. Now let's go through the scenario here. Kind of looks busy. It says the nurse is monitoring the 9-year-old patient's condition following an electrical burn injury from admission, which is day 1 to day 3. Review the trend data below and select the clinical findings that indicate a worsening condition requiring immediate notification of the healthcare provider. Select all that apply. So you have here columns of time point, vital signs, burn wound status, neurovascular status, and cardiac status, and lastly, diagnostics. Now let's go into the first row here. It says day 1 at 10 a.m. during admission. The temperature, it says 99.1 degrees Fahrenheit, pulse of 110, respirations 26, blood pressure 130/56, saturation 97%. The right thumb with, of course, the wound, the size is 1 square centimeter, right index finger 1 square centimeter, left palm 4 square centimeter, and the right chest has 1.5 square centimeter. It's erythematous borders and no drainage. The pulses are intact, sensation normal bilaterally. The PACs on ECG are present, no murmurs. And the diagnostic during day 1, it showed troponin of less than 0.04 nanograms per ml, CPK of 125 units per liter, and white blood cell count of 10.2. On the same day at 7 p.m., temperature is 100.4 degrees Fahrenheit, pulse rate of 108, respirations 24, blood pressure 128/54, saturation 98%. The chest burn increased erythema. There's also minimal drainage. The pulses are intact, sensations normal. The PACs remain unchanged, and the wound culture on day 1 now is showing Pseudomonas aeruginosa, resistant to clindamycin, sensitive to piperacillin tazobactam, which was actually reported on the second day. So it was obtained. The wound culture was obtained during the first day. However, the result came back on the second day. Now let's take a look into day 3 at 8 in the morning. Temperature is 101.2 degrees Fahrenheit, 112 for the pulse rate, 26 respirations, blood pressure 132/58, saturation of 96%. The chest burn now has purulent drainage. There's increased erythema. And the left forearm now is swollen. Skin is taut, diminished pulses, decreased sensation in fingers. The PACs with new occasional premature ventricular contractions. Now the ECGs show sinus rhythm, PACs, new PVCs, no ischemic changes. Quite a lot of information that you need to absorb here. Now, this is how you're going to approach this question. What you should do first is to analyze the trend data from day 1 up to day 3. You have to identify the critical findings and select these findings as required by the immediate provider notification. And so at this time, you have to exclude those minor changes that don't need urgent action according to the CJMM by the NCSBN. So let's get into the findings here. The first is increase in temperature from 99.1 degrees Fahrenheit to 101.2 degrees Fahrenheit. What do you think about this one? Is this indicating a sign of worsening condition? Does it need immediate notification of the healthcare provider? The answer to that is yes. We're going to place that check mark here because of the elevation in the body temperature. Over the 3-day period, it suggests worsening infection supported by the Pseudomonas culture and the purulent drainage that we have assessed here. And the fever also indicates a systemic response, potentially leading to sepsis if left untreated. And so this change needs immediate notification to adjust the treatment, especially with the antibiotic. the type of antibiotic. Now let's move on to the next one. It says change in chest burn appearance from erythematous borders on day 1 at 10 a.m. to purulent drainage on day 3 at 8 a.m. This is also deserve a check mark, because this alone is a sign of progression from red borders to purulent drainage, indicating active Pseudomonas infection confirmed by day 1 wound culture. This is also a clear sign. With the presence of the pulse, this is a sign of worsening infection and risking local tissue damage or possibly systemic spread. And your responsibility is to notify the medical provider right away to initiate the administration, or to ask the medical provider to select another antibiotic. And as we are seeing, the piperacillin tazobactam is the antibiotic that will target this microorganism. Let's take a look into the third finding. It says development of left forearm swelling and diminished pulses. This is day 3, 8 a.m. What do you think about this? This deserves a check mark, because this is a new change. This is worsening the swelling, the diminished pulses in the left arm, which were absent on day 1, right? And so these are suggesting compartment syndrome. This is a life-threatening, a limb-threatening emergency. And the compartment syndrome indicates pressure that is actually restricting blood flow, which could lead to tissue necrosis if not addressed surgically. So we definitely need to notify the healthcare provider immediately for an immediate surgical consult. Now, let's have our next finding. It says decrease in oxygen saturation from 97% on day 1 at 10 a.m. to 96% day 3, 8 a.m. What do you think about this? Well, there's not a lot of change here. It doesn't sound critical. It's not going to call for physician notification, so we're not going to select that. Now, what about new occasional PVCs on telemetry, day 3 at 8 a.m.? What do you think about this one? Yes, this is a big change. The appearance of the premature ventricular contractions on day 3, which was not present on day 1, indicates worsening myocardial irritability from the electrical injury. And the PVCs can increase the risk of ventricular arrhythmias, which could be life-threatening. So your role here is to notify the provider to ensure cardiology evaluation and monitoring. Alrighty, next we have increase in pulse rate from 108 beats per minute on day 1 at 7 p.m. to 112 beats per minute day 3, 8 a.m. So this is basically a increase in the pulse rate, and this is somewhat considered as minor. It's within the expected variation for this pediatric patient, especially that he's experiencing fever, pain, and infection, and it's not a standalone sign of deterioration requiring immediate notification, especially since the other vitals, the blood pressure, saturation, are stable. And the fever and infection are the primary concerns which cause the tachycardia. Now, what else do we need to highlight here? Or what would be the other finding that needs physician notification? Well, we have decreased sensation in left fingers for day 3 at 8 a.m. What do you think about this? Well, if there is going to be a decrease in this sensation, that is significant. If there is sensory loss that's new, especially in the left fingers, and if it is combined with the swelling and diminished pulses, these support compartment syndrome. And this also indicates nerve compression. This also escalates the urgency for surgical intervention to prevent permanent damage. So the role for this nurse is to notify the medical provider urgently, because this is a critical neurovascular finding. This is indicating worsening limb-threatening condition. Alrighty. I hope that you were able to capture all those correct answers and remove those distractors. Alrighty. Let's move on to our fifth test item. This is now the multiple response grouping. Now, let's scan through the scenario here. It says the nurse is preparing an SBAR report for critical changes on day 3. Select all details that should be included in each SBAR section for clear and accurate communication. There's also some updates in the nurse's progress notes for day 3 at 8 in the morning. It states alert-oriented reporting severe pain 8 out of 10. In the left forearm, pain minimally relieved by morphine at 0.1 milligram per kilo IV at 7:30 a.m. Vitals included temperature 101.2 degrees Fahrenheit, pulse rate of 112 beats per minute, respirations 26 cycles per minute, blood pressure of 132/58, saturation of the oxygen is 96% on room air, chest burn 1.5 square centimeter, fourth intercostal space, shows purulent drainage, increased erythema, culture from day 1 positive for Pseudomonas aeruginosa, resistant to clindamycin, sensitive to piperacillin tazobactam. Left forearm shows swelling, taut skin, decreased sensation in fingers. Neurovascular checks show diminished pulses in left hand. Telemetry at 7 a.m. shows PACs with new occasional PVCs. IV D5 half normal saline at 55 mL per hour continues. Now let's pay attention to the diagnostics here. It says ECG at 8 a.m. showing sinus rhythm with PACs and new occasional PVCs, no acute ischemic changes. And the wound culture that was collected on day 1 but was reported on day 2, it said Pseudomonas aeruginosa, resistant to clindamycin, sensitive to piperacillin tazobactam. So your task in this item is to again select all these components that should be, not all, but those components that should be included in each SBAR category or section. Now for the situation, we have background, assessment, recommendation. For the situation, it says fever of 101.2 degrees Fahrenheit and purulent chest burn drainage. Now, since we're talking about SBAR here, what you should do here is to select those relevant findings for each category in order that you will be able to fill the information for the situation, which highlights those urgent issues. And for the background, it provides the context. And for the assessment, it reflects the accurate information, data that's been observed all throughout the 3-day period, and also the diagnosis, and also the R, which stands for recommendation, suggesting actionable steps. So here, you need to choose those options and align your selections with the day 3 progress note. And so to answer this question correctly, make sure that you use the NCSBN clinical judgment measurement model to organize your clues logically and to propose targeted interventions for the patient's worsening condition. And for the situation, like I've already said, for the fever, for the first component, what do you think about this? Is this going to be included here? Well, the answer to that is yes. Place that check mark here, because with the pus and the fever coming from, of course, with the chest, right? The chest burn is now deteriorating. These are clear signs of a serious infection, and the wound culture showed Pseudomonas, which is a harmful bacterium, making this component urgent. And if not treated quickly, the infection could spread. It can cause sepsis. And when you put this component into the situation category, the nurse makes sure the provider knows to act fast, likely ordering another antibiotic. So this is actually noticing the problem and to decide what is urgent. Now let's look into the second component here. It says, all right, let me just select here. So it says here, left forearm pain, 8 out of 10, unrelieved by morphine. This is also deserving a check mark because the intense forearm pain is not getting better with the morphine, which is actually a strong painkiller already. So along the pain, there's swelling, there's weak pulses. These all suggest something serious like compartment syndrome, where the pressure has already built up and this could damage the arm permanently. So if you are going to include this under the situation category, you're actually telling the provider about this pain right away. So it will push them to check for a condition that might need surgery soon. So this is basically noticing problems and to decide what's urgent. All right, so this is basically a warning sign of a big problem. So it belongs in the situation to get quick action. Now, what about new PVCs on telemetry with ongoing PACs? This also deserves a check mark because the heart monitor is showing new premature ventricular contractions, which are abnormal heartbeats on top of the existing premature atrial contractions. Now, remember that electrical burns can mess with the heart, and the new PVCs means the heart may be getting more unstable, and this can lead to dangerous heart rhythm. So the provider needs to know now to involve a heart specialist or a cardiology, making sure that the consult is also updated. Now let's move on to our next item that needs to be included in the situation. The other one would be the left forearm swelling and diminished pulses. Again, this means that the blood flow to the hand is reduced, combined with the pain and the numbness. These all point to the compartment syndrome, wherein the pressure in the arms cuts off circulation. And if it's not fixed quickly with the surgery, the arm could be permanently damaged. Now, what else do we have here? There's also decreased sensation in the left fingers. So the patient stated that he cannot feel their fingers as well, which suggests the nerves in the forearm are already being squeezed or compressed, likely from the compartment syndrome. Now, this is a big deal because it shows the condition is getting worse, and this could lead to lasting nerve damage if not treated soon. Make sure that you include this under the situation category, which emphasizes the urgency for the provider to act, like possibly ordering a surgical evaluation right away. And this is going to fall into noticing problems, deciding what's urgent. And so for the rest of the options in the situation category, those are all incorrect. So the stable vital signs, something that you can easily eliminate. The patient's blood pressure, the saturation are within normal limits. So if the nurse kind of like judge that the patient has stable vital signs, well, it's partially true if we are just focusing onto the blood pressure and the oxygen saturation. However, the temperature, and there is also irregular heartbeat, so it's not really a stable set of vitals. It hides the fact that the patient has a fever, and there's also irregular and fast heart rhythm. So the patient is not stable overall. Okay, so we are not including that in the situation. That is something that you can eliminate right away. Now, what about the chest burn covers 5% total body surface area? Is it something that you should include? Of course not, right? The reason for that this is something that you should eliminate, it's because the chest burn alone is calculated incorrectly. So how did we determine this one? So if you go back into the first page or first slide in our PowerPoint, the calculation of the total body surface area was already indicated there, and we have the correct measurement. So let me bring this up one more time. And so the patient's burn areas are the following. There's that 1 square centimeter for the right thumb. There is also 1 square centimeter for the right index finger, and the left palm has 4 square centimeter, and the right chest has 1.5 square centimeter. And so this totals to 7.5 square centimeter. Now, for determining the total body surface area, especially in this 9-year-old weighing 33 kilograms, and the patient's palm, including the fingers, is about 1% total body surface area, which is roughly about 100 centimeter or 100 square centimeter, which is a standard estimate for kids in this age. And so to find out for the total body surface area, what you need to do is to divide the total burn area by the palm area, then multiply it by the 1%. So this will result into 0.075%. So this is our total body surface area calculation. So that's why the chest burn covers 5% total body surface area option in the component is incorrect. All right. Now let's move into the next incorrect option in the situation category. It says patient reports mild chest pain. Well, the progress notes did not mention any of chest pain. So this is a made-up symptom that doesn't match the patient's condition. And including this in the situation category would confuse the provider and will take the focus away from the real issues like forearm pain or infection. So it's not a truthful information. It's just a distractor that doesn't belong in the situation category. Now, moving into the background category, the following are electrical burn injury 3 days ago from 120 volt AC or alternating current. Is this going to deserve a check mark? Of course, because this is what happened to this patient. He had an electrical burns 3 days ago from a 120 volt source, which caused the burns and heart rhythm problems. So telling the provider this explains why the patient has issues like the infection or the irregular heartbeat now. And so this is going to set up the whole situation. All right. Now, what else? We have history of mild asthma managed with albuterol PRN. What do you think about this one? Yes, that is also part of the background because the patient has asthma, treated with an inhaler as needed. And this is a piece of information that is very important because it could affect breathing. The patient's breathing rate is a bit fast at 26 cycles per minute, and the medical provider needs to know about any lung conditions when planning the treatment. So this is correct because the past medical history, like this asthma, will help the medical provider make safe choices and decisions. Now, what else? There's initial burns on a right thumb, index finger, left palm, and chest. Yes, this also deserves a check mark here. These are historical data, and these shows where the burns are and how small they are. This is going to help the provider understand the chest burns infection and other complications. So this will also give context for the current problems. Now, what about wound culture from day 1 positive for Pseudomonas? This is also part of the background because the day 1 culture that was already reported on day 2 is already known, right? And so this is a past laboratory result, and this explains why the burn is infected now and helps the provider choose the right antibiotic or tazobactam. All right, so this is part of your background. It's a historical data that will guide the current treatment. Now, what else? The next option here is the information about the patient's, of course, patient age, 9 years old. So putting that check mark there. And also the patient's weight. Why are these important? These are crucial pieces of information which will be important in adjusting or calculating the antibiotic dosage, and also for medications that will be used for pain control, since this child needs doses based on their weight. And this is a very important step that will help ensure that the medical provider will prescribe the correct dose of medications. All right, this is part of safety. Now, the rest of the answers are incorrect. Diabetes, for one, well, it's false information. There's no history of diabetes. And so if you're going to add this to the background, this will give the provider wrong information, and this will possibly lead to unnecessary tests like checking the blood sugar, which is not needed here. Now, what about premature ventricular contractions and wound swelling? Why is this incorrect here? Well, it's because the PVCs and the swelling are new problems on day 3. It's not part of the patient's SPAST, okay? So when you are referring to the background, these will include historical data. But here, the premature ventricular contractions and wound healing are not historical data. These are new occurring issues during the 3rd day, right? So this too belong into the situation category. Now let's move into our next category, which is assessment. We have confirmed Pseudomonas aeruginosa infection. What do you think about this one? Yes, this deserves a check mark because the chest burns has pus, redness, and a fever of 101.2 degrees Fahrenheit, and the culture shows Pseudomonas bacteria. This means that burn is definitely infected, and the nurse needs to tell the provider so they can treat it with the right antibiotic. So this is part of noticing problems, making conclusions. Now, this is correct because the evidence clearly shows an infection, making this a correct diagnosis. Now, what else? We have suspected compartment syndrome in left forearm. The forearm is swollen, tight, painful. There's also weak pulses and numbness, which are all signs of compartment syndrome. And this happens when the pressure builds up and cuts the blood flow, and it's a serious problem that might need urgent surgery. So the nurse's job is to flag this as a likely issue, part of noticing problems, making conclusion. All right, this also match the compartment syndrome, which is a valid concern. What else? We have new PVCs with ongoing PACs. No ischemic changes. Why does it belong in the assessment? Well, of course, this is a current finding. The heart monitor shows new PVCs, ongoing PACs, but the ECG says there's no heart attack. So this means the heart is having more rhythm problems, likely from the electrical injury, and needs monitoring frequently. So here the nurse correctly notes this as the heart's current state. And this also describes the heart's issue current accurately and will guide further care. Now, the rest of the options, such as elevated troponin indicating myocardial injury, well, we know that troponin tests for heart damage, but the notes do not show any new troponin results. And take note, on day 1, it was normal, correct? And the ECG shows no heart attack signs or no MI signs. And saying that troponin is high is wrong, and it suggests a heart injury that isn't there. Now, what else? We have chest burn healing well, no infection. This is untrue because the chest wound has some pus. It's positive for Pseudomonas infection. And saying that the chest burn is healing, it ignores the obvious infection signs, which could mislead the healthcare provider into not treating the infected wound. And we have the recommendation category. The following components are: request piperacillin tazobactam IV per culture sensitivity. This deserves a check mark because this is what it really said in the wound culture lab result. And the Pseudomonas is sensitive to the piperacillin tazobactam antibiotic. So asking for this antibiotic is the best way to fight the chest-borne infection, and this is to stop it from getting worse, like causing sepsis. So the nurse should suggest to the medical provider to start the treatment as urgently as recommended by the culture and sensitivity wound result. Okay, this is the correct right drug for the infection based on the culture. Now, what else? We have request urgent surgical consult for possible fasciotomy because of the forearm swelling. There is poor pain control from the morphine. There is increasing pain on that affected extremity. There's also weak pulses, suggesting compartment syndrome, which might need an urgent fasciotomy to relieve the pressure. And so asking for this urgent surgical consult will save the patient's arm from the permanent damage. Now, what else? There's also a need for us to highlight or check notify cardiology for new PVCs, because the PVCs, which are new assessment findings, mean that the heart rhythm is getting worse, and the heart specialist would be required to check if it's dangerous. So the nurse should recommend this to the healthcare provider to make sure the heart stays safe. And we also have to monitor neurovascular status hourly. So this is going to check the forearm's pulses and sensation every hour to monitor whether the compartment syndrome is getting worse. And this helps the surgeon decide if surgery is needed soon. Also going to prevent arm damage. Now, the rest of the options are incorrect, such as administer acetaminophen 15 milligrams per kilo PO for fever. We know that the patient is already having fever. So treating the infection with the antibiotics is more important than just lowering the fever with the acetaminophen. And this has already been in place. This has already been ordered, correct? And this is not urgent compared to the surgery or the antibiotics. Now, what else? There is increase IV fluids to 100 mL per hour. So upon noticing this, I really want you to go back into the vital signs, pay attention to the blood pressure. The blood pressure of this patient is within normal ranges. They're not dehydrated, and the current fluid rate of the regular IV fluid, which is 55 mL per hour, is actually fine for this 33 kilogram child. So if you're going to add more fluids, this could make the forearm swell some more. And it's not really needed for this patient with a very minimal area of burn injury. It's unnecessary, and it could cause harm, causes fluid overload. Now, what else? We have obtain repeat wound culture now. What do you think about this? This is not going to deserve a check mark here because the day one wound culture already shows the Pseudomonas, and it already pinpointed what antibiotic can target the microorganism. Now, the pus and the fever match that infection, so there is no need to do another wound culture, and waiting for new results would actually delay starting the right antibiotic. So at this time, it's not needed, and it also slows down the treatment. Alrighty, I hope that you're able to capture all those correct components and making sure that these were assigned to the correct SBAR category. Let's move on into our last test item.
Before moving ahead, here's something you need to hear. If you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
This is an extended drag and drop, and let's take a look into the scenario. It says the nurse is caring for the 9-year-old patient on day 3 at 8 a.m. following an electrical burn injury. Based on the nurse's progress note and diagnostic results, place the interventions in the correct order of priority to address the patient's critical changes: suspected compartment syndrome, confirmed Pseudomonas infection, and new PVCs. Your task is to drag and drop the interventions from the list below into the priority boxes, ranking them from the highest to lowest priority. So here are the list of interventions. It says increase IV fluid rate to 100 mL per hour, request piperacillin tazobactam IV per culture and sensitivity, notify cardiology for new PVCs, monitor neurovascular status hourly, administer acetaminophen 15 milligrams per kilo for fever, and request an urgent surgical consult for possible fasciotomy. Let's start. The intervention that should be placed with the highest priority is request an urgent surgical consult for possible fasciotomy. Why? The reason for that is because the patient's symptoms marked by the swelling, obviously the nurse already noted this, right? There's also tight skin, there's extreme pain uncontrolled by the morphine, there's also weak pulses, there's numbness or loss of sensation. These are classic signs of compartment syndrome, and this is a true surgical emergency. So if this condition is not treated right away, this can cause permanent muscle and nerve damage, could probably lead to limb amputation if not relieved urgently. So this one calls for prompt fasciotomy to restore the circulation and also to prevent irreversible complication. And so in nursing, anything that threatens life or any limb, always take top priority, okay? So the compartment syndrome can become irreversible in as little as 6 hours, which is why this intervention must come before anything else. Now, what else should be placed in the second priority? That is going to be notify the cardiology for new PVCs. We're talking about new onset PVCs after an electrical burn, which suggests myocardial irritation, and this can be early warning of worsening ventricular arrhythmias. Although the patient is stable at this time, notifying the cardiologist will allow them to intervene early and for us to monitor for potential deterioration. And the reason why this places into the second priority is because or slightly below the compartment syndrome, because the heart rhythm issue has not progressed to an immediate crisis yet, but it still requires urgent attention to prevent sudden cardiac arrest. It said new PVCs. It did not say series of 5 PVCs. Those are two different things, and that's why we did not place this in the number 1 spot. Now, what about the third priority? Which one of these interventions should take that spot? This should be request piperacillin tazobactam IV per culture and sensitivity. Because the patient has Pseudomonas infection, it's confirmed by the culture, plus a fever and purulent burn wound, signaling serious infection. And this calls for timely administration of antibiotics, which is crucial to stop the infection from spreading into sepsis. And this usually, we know that sepsis can occur, right? This can happen over hours, even days, unlike the rapid onset of limb ischemia. And that's why this is placed as the third priority, right? It is urgent, but it doesn't come before the surgical or cardiac emergencies. Now, for the fourth spot, what do you think would be that intervention? This is going to be monitor neurovascular status hourly. We're going to have to check the pulses and sensation hourly. This is vital to monitor for worsening compartment syndrome. This action is supportive, not corrective. That's the key word here. It provides data, but it doesn't treat the problem. That's why it's taking the fourth spot. This is part of monitoring, but it should follow actions like getting the surgical team involved. Monitoring without initiating treatment also delays care. And lastly, in the fifth place, that's going to be administer acetaminophen 15 milligrams per kilo for fever. The fever control with this antipyretic helps the patient feel better, but it does not address the root cause, which is the infection causing compartment syndrome. And managing the symptoms is a lower priority than treating the infection directly with the antibiotic. So this is part of a comfort measure, and assumes the nurse has a PR in order. It's not life-saving and should come after critical interventions that we have already chosen. Now, lastly, we have the IV fluid, right? Increase IV fluid to 100 mL per hour. So pay attention again to the vital signs of the patient. The blood pressure is stable. Oxygen is stable. Though you have noticed that there's already fever and there's irregular tachycardic rhythm. More fluids are not needed around this time because the patient is already receiving the maintenance IV fluid, correct? And if you're going to administer this increased rate, this could do more harm than good. And in fact, it may exacerbate the compartment syndrome here. So if you probably prioritized the administration of acetaminophen, or let's say the IV fluid, this is wrong, because again, addressing fever and administering a higher fluid rate is not really addressing the clinical urgency, which is the compartment syndrome. This is not life-threatening, and there is no urgency for administering a higher IV fluid volume. Now, if you selected cardiology to take the first spot above the surgical consult, even though we know that PVCs and infections are both serious, the PVCs don't pose the same immediate risk compared to the permanent damage that can occur with the compartment syndrome. So time is issue in this compartment syndrome. Now, if you put the monitoring of the neurovascular status hourly, this will not save the limb. It will not stop the infection, or it will not treat the arrhythmia. It is only a supportive treatment, but doesn't replace initiating those life-saving intervention. And it should not come before those actions that can stop worsening of the client's condition. So I hope that you were able to use your critical thinking in these exercises. So as you've seen through, we have some difficult questions tackling this case with electrical burns. I hope that these sharpened your clinical judgment. And don't forget to apply the NCSBN clinical judgment measurement model that you've practiced, so it will help you spot those critical cues like the swelling of the extremities, new premature ventricular contractions, or purulent drainage, so you can prioritize those urgent issues and selecting safe, effective intervention. So in this case, you also avoided pitfalls like unnecessary treatments and used tools like the SBAR, or the Situation Background Assessment Recommendation, and also the trend analysis to stay organized. And you need to keep honing these test-taking skills to confidently handle more complex scenarios, so you can ensure that you're ready to excel on the next generation NCLEX and deliver top-notch patient care. And that's the end of our Q&A today. Thank you for joining this session, and I want you to keep practicing your clinical judgment, and don't forget to hit the subscribe and like buttons to stay updated with more review content. And also share this content with your friends reviewing for the NCLEX-RN. See you in our next session.